Hello everybody, I am presenting the histopathology set for second M.B.B.S students, and as you know it is useful for you for the slide spotters with OSPE stations and also useful to the table viva on the slides that you are supposed to draw and answer the viva. Let us start the first slide please. Identify, describe and mention the sites. Now these are the low power views and you can see some blue structures, colonies of the bacteria here and surrounded by the inflammatory cells. The high power view shows that this is the filamentous colony of the bacteria which is at the periphery showing pink material. This pink material is there and that is known as splendor Hopley phenomenon. Subsequent to that, the surrounding tissue shows neutrophils, lymphocytes, histiocytes and occasional giant cell. So this is the filamentous clump of the bacteria as depicted by the blue arrow. The red arrow shows the granulomatous reaction to the filamentous bacteria. Now the diagnosis of this case is actinomycosis. Now actinomycosis is chronic suppurative granulomatous infectious disease caused by anaerobic bacteria called as Actinomyces israeli. Please remember this name, anaerobic bacteria Actinomyces israeli. Microscopically, bacterial colony, also known as sulfur granules on the clinical side because there are sinuses and some granular material comes out through the sinuses on the feet generally. These are surrounded by pink rim at the periphery, as you see here, pink rim at the periphery due to deposition of immunoglobulin and cell debris and is called as splendor Hopley phenomenon as depicted by this blue arrow. Surrounding tissue, as I told you, shows granulomatous reaction with neutrophils, lymphocytes, histiocytes, fibroblasts and few giant cells. What are the sites for actinomyces? The foot, sole of the foot. There are museum specimen in most of the medical colleges showing sinuses and edematous foot. This is actinomyces. Cervicofacial actinomycosis may be there after a dental infection or extraction. If there is bowel perforation, it may be complicated by actinomycotic granulomas. In females, if there is intrauterine device kept, it may get infected with this anaerobic bacteria causing actinomycosis. So after actinomycosis, we move to the next slide. Okay, this is the lesion with high power of which has come first. Doesn't matter. Now the identify and give reasons. Mention the etiology and diagnostic investigations for this condition. Now this is the low power view and I am sure you can identify these colloid filled follicles which are from thyroid and they are atretic, small in size. So atrophic or atretic colloid filled follicles also seen in the higher power like this. This is the colloid filled follicle and the stroma shows distinct feature which is the presence of lymphoid follicles with germinal center. So the pale area in the center is germinal center and surrounded by dense lymphocytic infiltration. So lymphoid follicles with germinal centers. Then there are some follicular cells which are enlarged and granular, and these are shown in the inset in this. Large cells, large follicular cells which are having granular cytoplasm are known as Hurdle cells or oxyphil cells. Right there. The diagnosis is Hashimoto thyroiditis. Hashimoto thyroiditis is an autoimmune disorder. Lymphocytic and plasma cell infiltration with germinal center formation as depicted by the yellow arrow is the characteristic feature. The thyroid follicles are destroyed by cytotoxic T cells. So the destruction of the thyroid tissue is mediated through cytotoxic T cells. Hurdle cells, as shown here in the red arrow here, are eosinophilic granular cytoplasm and having vesicular nuclei. The diagnosis of Hashimoto's thyroiditis has to be proved by the laboratory features and tests for the detection of autoantibodies. Autoantibodies are of three types: anti-thyroglobulin antibodies, anti-TSH antibodies specific for Hashimoto's, and antimicrosomal antibodies. So you see the thyroid follicles atrophic, lot of lymphoid follicles, and then ask for the anti-thyroid antibody to confirm the diagnosis of Hashimoto's thyroiditis, right? So Hashimoto's thyroiditis. Next slide. Identify, give reasons. Now this is the low power view of a case wherein you see the papillary structures. These are the fibrovascular cores and there are the papillary structures, and these are overlined by the cells which have got nucleus, the cytoplasm of which is the nucleus of which is clear. In addition, what you see here is in the papillary core there is calcification or Samoma bodies. So papillary structures, Samoma bodies and nuclear chromatin clearing should give you the hint for the diagnosis of papillary carcinoma of thyroid. Another features of papillary carcinoma of thyroid are, see this at the tip of the arrow, the nucleus which is enlarged shows intranuclear groove. So intranuclear groove is seen, intranuclear groove is seen, and this cell shows the hole in the nucleus. This is known as intranuclear inclusions. Here you observe the nuclear overcrowding or overlapping. So papillary carcinoma of thyroid is the diagnosis of this case. The lesion showing papillary structures with fibrovascular core as seen by the red arrow and overlined with the tumor cells. The tumor cells in addition show Samoma bodies as depicted by this blue arrow, calcified areas. So this can be MCQ also. The diagnostic nuclear features include nuclear enlargement or overlapping as seen here, optically clear chromatin or ground glass appearance or what are known as orphan ani nuclei like this, this and this. Then nuclear grooves as depicted by the yellow arrow. you can see some nuclear grooves here also, and green arrow showing the holes or the inclusions, pseudo inclusions in the tumor cells. So the diagnosis, papillary carcinoma of thyroid. Very easy slide. Next, identify, give reasons and mention radiological findings. This is the low power image and this is the high power image of the same. Now what you see here is the spindle shaped cells, hyperchromatic cells, and these in between you see the stroma is showing deposition of pink hyaline homogeneous material. Better appreciated here, these are the tumor cells, spindle shaped cell tumors, and they are showing nuclear pleomorphism, some abnormal mitotic figures, and also osteoclast-like tumor giant cells, osteoclast-like cells. So the tumor which is producing this material is osteoid. That means non-mineralized bone material. So osteoid is homogeneous eosinophilic non-mineralized bone substance secreted or produced by the tumor cells of osteosarcoma, which is highly malignant metaphyseal bone tumor. So this is important slide. This is composed of spindle cells with production of osteoid, which is a dense eosinophilic intercellular material, and depending upon the matrix may be osteoblastic, chondroblastic, fibroblastic or telangiectasis. If you have a question in theory, you have to write this, because if the stroma of osteosarcoma shows chondroid differentiation, predominantly it is known as chondroblastic osteosarcoma. If it shows lot of blood vessels, it is called as telangiectatic, and fibroblastic and osteoblastic. So bizarre nuclei, multinucleated giant cells, and the nature of matrix will decide the suffix to the osteosarcoma. So this may be classical osteosarcoma or chondroblastic osteosarcoma or telangiectatic osteosarcoma, right? Radiologically, and this is the key question, MCQ question and so on. Radiologically, it shows Codman triangle and sunburst appearance. Now what is Codman triangle? As the tumor expands and breaks the compact bone at the maximum expansile bone site, the proximal periosteal tissue is elevated, and it also starts producing reactive bone. So reactive bone is seen in the X-ray. So reactive bone of elevated periosteum and the compact bone of original bone from where the tumor is arising gives a triangle appearance. So that triangle is known as Codman triangle. And the tumor is very vascular, and along the tumor the mineralized bone may be deposited, giving rise to sunburst appearance. So important thing in osteosarcoma is its radiological finding. Now you are requested to subscribe the channel. Just write Dr. Sanjay Deshmukh Pathology on YouTube and you will get my videos on pathology. Now I am also, besides the histopathology, urine examination, I am also producing some more videos on the MCQs, and if you have some suggestions, please let me know by your comments, valuable comments. Also like the videos and press the bell icon to get subsequent notifications. I have now a URL given by YouTube, and this is my URL. If you copy it and click it, you will get all the videos by Dr. Sanjay Deshmukh at single click. So please remember this. Next one is identify and describe the abnormal cells. Now one point has come up, and the background is polymorphous with eosinophils, plasma cells and neutrophils. Okay. Now what is the image like? This is the image. Now what you see is there are many lymphocytes, and as is written here, the background shows eosinophils, neutrophils and plasma cells. But in addition, you also see some large cells, and these are the diagnostic cells and important cells in this lesion. This is Hodgkin lymphoma. Some people say Hodgkin's lymphoma. However, many textbooks write it as Hodgkin lymphoma. So morphologically, the diagnosis of Hodgkin lymphoma rests on the neoplastic cells. Now the neoplastic component in this lesion is Reed-Sternberg cells, which are abnormal cells, and the rest of the population is non-neoplastic. Now you have to remember the classical morphological features of Reed-Sternberg cell. Now this is the mononuclear Reed-Sternberg cells. Observe the cell, it is very large compared to the lymphocyte. You can appreciate this is a very large cell. The nucleus is very typical. It has got very distinct eosinophilic nucleolus, and there is a perinuclear halo, and the nuclear membrane is again very distinctive. So this gives appearance of owl eye. So owl eye like nucleus with eosinophilic distinct nucleolus, perinuclear halo and nuclear membrane distinct. In addition, there is lot of or moderate to abundant eosinophilic or acidophilic cytoplasm, and in many cases you find pericellular halo, which are known as lacunar cell. So Reed-Sternberg cell description is important. This is mononuclear Reed-Sternberg cell. Now classically they are binucleate and they are mirror images of each other. Now you see this nucleus, you see this nucleus, and these are again acidophilic nucleoli, and they are like twin or mirror images of each other. Another type is polypoidal or popcorn like nucleus of a Reed-Sternberg cell. And one more is that of pycnotic shrunken nucleus, what is known as mummified Reed-Sternberg cells. So you must describe various types of Reed-Sternberg cells. Now Hodgkin's, invariably you will be asked what are the types of Hodgkin's lymphoma. Based on their morphological features, types, stroma, and the types of the Reed-Sternberg or RS cells, WHO classification describes 5 types. One is nodular sclerosis HL, mixed cellularity HL, lymphocyte rich Hodgkin's lymphoma, lymphocyte depletion Hodgkin's lymphoma, and this is little bit new, nodular lymphocyte predominance Hodgkin's lymphoma. And the types are of RS cells are mononuclear like this, binucleate mirror cell like this, polypoidal or popcorn like this, and mummified or shrunken nucleus, pycnotic nucleus like this. So Hodgkin's lymphoma, important slide, important lesion, and maybe short note, long question on lymphoma. This slide will help you in answering so many things, including MCQs. Let us go to the next lesion. Identify, give reason, and mention cell of origin. Now, this is the low power view, and you can identify the tissue or organ very easily because on the left side you can see the glomeruli. So, this is the kidney and this is the tumor. Now, tumor on the low power also you can identify as the papillary structures, some tubular structures, and interlacing chondroid or trabecular, not chondroid, trabecular pattern. This is the high power view of the same lesion. What is important is the appearance of the cells. They appear clear. Cytoplasm is clear because during the processing, H&E staining, the glycogen and the lipid in these tumor cells has been washed off. So they appear clear. The nucleus doesn't show much of pleomorphism, and the arrangement is papillary and tubular and trabecular. And the stroma is composed of vascularized fibrous septi forming lobules. So this is a classical slide of renal cell carcinoma, clear cell type. Cells arranged in papillary, tubular and trabecular structures. The cytoplasm is clear. Removal of glycogen and lipid in the processing is the cause of the appearance as clear cytoplasm. Stroma shows thin vascularized fibrous septi. Other types of the RCC include papillary RCC, chromophobe RCC, etc. The question may be renal tumors and write details about the RCC, but for practical purpose it is sufficient to identify the lesion. So cell of origin for RCC is renal tubular epithelium. This is also known as hypernephroma, but that is a misnomer. Therefore, they may ask you cell of origin and it is renal tubular epithelium. The eponym for this is Gravit's tumor in some of the old textbook. So after this, I thank you very much and please await my further new videos. Thank you. Thank you.